I want to thank everybody for participating in the Journal Club tonight. We've been doing this now for, I think, about a year and a half now. I'm Chad Tatini, the chair for the Young Aesthetic Plastic Surgeons Committee, and we do this monthly Journal Club, and we alternate with the NGE committee. So again, thanks for coming. We've got a great topic tonight. As a matter of fact, yeah, I think this is the most people that have ever signed up since we started. So it's shows you that we've got great people participating tonight and a great topic. So Hunter, thank you for helping and organizing this. Thank you to ASAPS and ASJ. The article we're going to be discussing tonight is the tissue-based triad and augmentation mastopexy, single-stage technical refinements by both doctors Kyle Saniak and Dr. Bill Adams. I'd like to thank Dr. Adams for presenting the summary of the paper tonight. We'd also like to thank Kiya Movassaghi for moderating the panel tonight. I should mention that neither of them have any relevant disclosures for tonight's talk. So it's going to be about 30 to 40 minutes. If anybody has, we really encourage interaction. So if anybody has questions, raise your hand, talk. If you don't want to do it that way, you can just chat myself or Kiya privately, and we'll go ahead and field the questions, either facilitate them or send them over to Dr. Adams. So without further ado, I'm going to hand it over to Dr. Adams here to present this wonderful paper tonight.
Okay, thanks a lot, Chad, and I'd like to welcome everybody. It still sounds like there's somebody in an air tunnel or in a helicopter, but I'm not sure what the deal is there. But anyway, I want to, I'm so excited to go ahead and present this to the group. And this is the paper that we're going to talk about, as Chad mentioned, just published in the December issue of ASJ. But just to put this in perspective, this is really the second part of a series of papers. The first paper, which was published in a lesser journal to ASJ, and that journal is one which you shall not name, but it was published in 2013. So it was really the concept paper of the tissue-based triad concept for augmentation mastopexy. And basically there's two big aspects of that concept. So the first is that the Renault classification, as many of us were taught in residency, is really non-specific in terms of the relation of the nipple to the inframammary fold. And in terms of determining, say, if you're seeing a patient who you're saying, does this patient need to have an augmentation mastopexy, or can I treat them with a mastopexy, that assessing the global laxity in the breast is a better way to determine that. So in that paper, we kind of described two measurements: the nipple to fold measurement on stretch and the skin stretch measurement, which is a measurement of anterior posterior laxity. And so if you have a patient that has a nipple to fold and stretch less than 10 and a skin stretch less than 4, you can generally treat those patients with augmentation alone. And if they have a nipple to fold greater than 10 or a skin stretch greater than 4, that indicates that patient has a greater degree of laxity. And then we had a second concept which we introduced that you can see on the right-hand side of the slide, which was the concept of vertical excess. And so vertical excess is a really important concept. It's basically measured by picking your nipple position that you're surgically where you surgically want the new final postoperative nipple to be, and then you're going to measure down the desired nipple to fold length for that particular procedure. And then everything beyond that to the inframammary fold is your vertical excess. And so the second part of the tissue-based triad concept was deciding who is going to be a candidate for single stage augmentation mastopexy versus a two-stage. And so the cutoff was about a vertical excess of 6. And so that was that paper. And so the second paper, which is our journal club discussion, was really to look specifically at single stage augmentation mastopexy. And the reason that is that in our series, 85% of the cases in the series were single stage augmentation mastopexy. The key points from the paper, and again, I'm not going to go over every single detail, but number one is implant selection is different than you will do for breast augmentation alone. So generally, we're using lower profile implants for this procedure. Not only is that because many of these patients have breast tissue, they don't really need projection, they need fill, but specifically they need height. They need a proper height of the implant and to fill the upper pole of the breast to produce a good aesthetic outcome. So lower profile implants, the technique we do in all these cases is a central mound, bottom up mastopexy, and we'll talk a little bit more about that. But the markings are guided by vertical access, and actually the paper has some very good videos in it that I think illustrate all these in good detail. The sequence is really to separate the two procedures. So we actually do a dual plane augmentation first. We close off that implant from the rest of the procedure by doing a running stitch of the superficial fascia, and then we do the mastopexy. And that's one we believe that's important in terms of minimizing device-associated issues such as capsular contracture. And then the paper also discusses some really key technical nuances. Again, a dual plane pocket. We use a little inferiorly based dermal flap that you can see in the paper just to kind of help unify that T-point closure, as well as if you do get any delayed wound healing, it tends to be a more vascular wound to heal a little bit easier. And then inframemory fold fixation sutures to secure your inframemory fold at the level of the fold to prevent any riding up of the incision onto the breast. The other thing is that we call this a bottom-up mastopexy, again, because many of us were taught in residency just to sit the patient up and pick the nipple position, but I believe that introduces many different variables that are very hard to control when you have a patient in the operating room table that's draped out. So we actually prefer to mark the nipple as it's showing here. I'm not sure if that video projects, but we place the skin on stretch and then measure up our desired nipple to fold distance. In this paper, this is a chart that you see that was in the paper, and I don't think this is an end all be all, but I think there's some important concepts in kind of discussing nipple to fold length. And I think that the first thing is that control nipple to fold length controls breast aesthetics, because ultimately the ratio between the width of the breast and the nipple to fold length is a proportion that, when it's correct, that's what we deem an aesthetic breast. So when we're doing these procedures, having some idea of what our desired nipple to fold length is and controlling that is really important to control predictable breast aesthetics. In this paper, we had some relationships based on the width of the breast for a desired nipple to fold planning index for both mastopexy, you see below here, and augmentation mastopexy, which are above. And I think one important differentiation is if you're doing an augmentation mastopexy with the implant, and for those of you doing a lot of those, you realize this, you need to actually have your nipple, you need a longer nipple to fold length because you're filling the upper part of the breast, which will tend to make the nipple look lower. So those relationships, again, they're not perfect, and I don't think this is something it can be just a rote thing, but I think that they're helpful to start with, and then using this technique, I think that you'll find that you have far less variation in your nipple position versus just sitting the patient up and trying to pick where you think it looks right. So this was the data from the study. There's 251 patients. The average implant size was about 285. The average follow-up was about 1.5 years. And then the complications you can see on the right-hand side. So reoperation rate was about 3.6%, which is one thing. That was really one of the things that we were trying to do when we originally undertook this 6 years ago, is to minimize reoperation. So, but overall, the complication rates I think were quite acceptable. Again, these are just pictures from the paper. The one thing I was going to mention is this patient here. This is a patient where she really doesn't have very much breast tissue at all. So that's one caveat. I said we use lower profile implants, but in a patient like this, we will use a moderate profile implant because she just doesn't have any breast tissue. But the patients that come with more breast tissue, we tend to use the lower profile implants. So, in conclusion, the tissue-based triad for augmentation mastopexy, this is really, and this is what we concluded the paper with, this is really a process-oriented approach. I really like making things into processes, because I think as you get busier, it becomes a bit harder and harder to remember different steps. And so having some infrastructure when you're thinking about these procedures is very useful. I oftentimes hear people say, "Oh yeah, well that's great concept. It's good for when you're a resident." But what I would submit to you is, I think it's better for all surgeons of all levels. And if you don't believe it, I think you should try it. I use this every day, and it's really simplified my ability to consult with patients and do these procedures. But we found it to be predictable, safe, have very low reoperation rates, and a high patient satisfaction. So with that kind of summary, I'm going to turn it over to Kiya, and Kiya, lead off the discussion.
Both of your papers, and I actually have enjoyed reading both, picked up a few things from it. And I want to encourage others to join the discussion as we go through the paper. I'm going to kind of dive in the paper a little bit more details and maybe bring some of the details to light. In general, I love the fact that you separate your pockets. I still hear talks by other, well-known speakers that they go through the vertical limb of the mastopexy and into the pocket. At the same time, they talk about, following the 14, steps. And I think I like about your technique is that you actually make your pocket inferiorly, then you seal it before you do your mastopexy. And I think that's what reflected in your data. I don't know, you have one of the lowest capsular contracture rate that I've seen of all these Augmentation papers published. And Augmentation usually is more prone to capsular contracture. So I think that's probably very important not to contaminate your pocket. The other thing I like about your technique is the fact that you preserve that dermal kind of, what do you call it, the Adams flap at the bottom, which is kind of your insurance policy to cover your T-junction in case your T-junction falls apart. I use something similar to it, not exactly the same thing, but I do also preserve a cuff tissue there. The other thing I like about your technique, which you mentioned in one of your videos, is the fact that you do a very precise pocket development. It's one of the things that you see a lot of folks mistakenly over dissect the pockets, especially laterally. They have to realize that the lateral pocket dissection is dictated by the width of your implant, not the width of the breast. And I think you mentioned that in your paper. You mentioned that you do dual plane too, pretty much I think for all your cases, which is great if you're doing a sub picture. But I want to actually ask the question, whether you ever do a pre-pectoral, like a subfascial Augmentation, or is it always a dual plane submuscular? That was like my first question.
Yeah, so really, we've really stuck with dual plane for all these cases. And I know it's been a little bit more in vogue that people are doing more subglandular pocket planes, but the one thing that I think that it's, and I think you can get very good results with that. And I agree with some of the stuff that's out there that the capsular contracture rates, when people talk about subglandular, is really probably different techniques. So if you're using good technique, you probably can have a similar contracture rate. The one thing that's different though is the minute you do a subglandular pocket plane, you've changed the blood supply of that breast for the lifetime of that patient. And so, for my way of thinking about it, I prefer to keep it under the muscle because that really, it maintains options for the patients 20, 30 years down the road where they may need to have things done, but if they don't have great blood supply, it may limit you. So that's been our approach.
Speaking of the blood supply, one of the things I noted in your video as you were making your mastopexy dissection, I noted that you make the cut around the dermis of the keyhole as well as all the way down. So what's the pedicle to your nipoareolar complex? Is it supromedial or what's your pedicle?
It's really a central mound. So it's actually all the way around. You've got superior, medial, lateral, inferior, because it's a true central mound pedicle.
Okay. You mentioned that you're using a lot of the form-stable implants, low-profile form-stable implants. But when I looked at your table 3, I noticed actually majority of your implants were the sort of the old-fashioned generation 4 Nasal 10, 15 implants that were not necessarily form-stable. I also know that you had been using some tear-shaped implant. Has there been a change in your kind of your thought process as we've had more and more different types of implants available in the market, or why is that?
Yeah, I think more of the round form stable implants or more form stable implants. I guess form stable is kind of a, when does something become form stable, but certainly the more cohesive implants, there's been a number in the past couple of years that have become available that weren't available at one time point. So when we started this series, back when that first concept paper came out, that we were using the Gen 4 implants. But I do like the more form stable implants. I like the more filled implants. I like a more optimally filled device, and so that's what we tend to use in these type implants. And all the implant companies have some variations on that, but we're usually using lower profile implants in general.
Can you clarify for the audience? You mentioned that your implant selection is different in AUG alone versus Augpexy. Can you just clarify how you go about selecting your implants in Augpexy versus AUG alone?
Yeah, so in breast augmentation, and this goes back to the high five process. You're trying to optimally fill the breast, and so you're assessing the breast space width of the breast, and that's your giving you a starting implant volume. But then you're adjusting it based on the envelope. So if the envelope is more loose, you need more volume to optimally fill that. Whereas in augmentation mastopexy, and this is really important, this is where people get into trouble. If they use the same principles, you're going to be taking away that skin. You're not trying to optimally fill the preoperative breast. What you want to do is optimally fill the postoperative breast, that you're removing skin and you're removing breast tissue. And so you really don't want to adjust for the envelope. You want to basically pick the implant based on, I pick it on the width and the height that we're wanting to get with that implant. And usually in our series, again, it was average 285, but it's usually between 200 and 300 cc's for the majority of those patients.
So your the implant width is a little wider in your Augpexy than your AUG alone. Is that correct?
Well, I don't know if it's wider. I think basically, in augmentation, generally, you're going to be using a moderate plus. That's kind of the workhorse implant for I think most people. In this, we're using either low profile or low plus profile, depending on depending on what implant manufacturer you're going to use.
Okay. Now you mentioned that obviously for the novice, so you're talking about your technique and how you measure them is preoperatively. When you go to the operating room, do you commit to that markings that you've already done during the preoperative session, or do you put the implant in and then remeasure the patient? Because I think it's key I want to make sure that the younger surgeons don't walk away from this and try to become too cavalier about this thing. And because you make your cuts, and if you have misjudged your measurements, then you burn a bridge and you cannot go back. So what's your recommendation for the novice surgeon?
Yeah, I think that's a very good point, and I absolutely do just as you say. And I know there are people out there that do it the opposite way. They do the mastopexy first, and that doesn't make in single stage. If you do the augmentation first, when you mark the patient, you think you're predicting what the response of the breast tissue to that implant is, but it's not always 100% predictable. And my residents, the great Kyle Saniak, who wrote this paper, he can tell you, like, we always do the augmentation first, and then we check our marks to see. And I would say at least 20-25% of the time, I'll adjust those marks, and it's usually that you've overmarked it. So it's not usually not taking out more skin. But that's a problem. If you commit and then you find it's too tight, then you're in a pickle, and it's not a good situation. So I think that's a very good point. Yeah, we do the exact same thing for that reason.
Very good. Now I want to clarify something in your marking. I couldn't quite follow when I was watching your video. When you talk about you measure your vertical excess, and then the vertical excess, you use that to determine the width of your IMF incision. So your IMF incision was twice the width of your vertical excess. And then from there, you went back and you determined what the divergence angle of your vertical limbs is going to be. I was just trying to figure out how you figure out that angle. What was your guideline?
Yeah, so again, the vertical excess is determining all that. So the infirmary incision length, as you say, is 2 times the vertical excess, and then the lateral and medial point. Then you can just take your ruler and measure back to, the original arc that we drew from your nipple down to your desired infirmary fold position. There's a little arc above so that's your desired nipple to fold length. So then whatever from that point on the infirmary fold to that arc, whatever is the vertical excess where it intersects that's determining the angle of divergence of your mastopexy.
And the arc that you're talking about, is it based on, so how do you determine the width of that arc? I know how you came out the meridian of the breast, but how do you determine the two ends point of that arc?
So it's and I think there's a video in the paper that shows this. So we're measuring, say we have a 12 centimeter wide breast and we want the nipple to fold to be 9 centimeters. So we measure with our measuring tape from, say, Patangi's point, understretched down 9 centimeters, and then you just mark along the lower part of the breast, a little arc that's all 9 centimeters from your nipple. And then you measure up from the infirmary fold of those lateral and medial points towards that arc, and wherever the vertical excess, whatever the vertical excess is, if it's 5 centimeters, wherever that intersects the arc, that's going to determine those 2 points.
Got it. And you mentioned that along the Pitangui point, your nipple will be a little higher because of the higher volume of distribution with the implant. Now, do you take into account the bottoming out of the smooth implant with time? Because at the end of your paper, you mentioned that you're using more and more GalFlex mesh with your patients. So I suppose, even though your complication rates are very low, I suppose you're seeing some bottoming out. That's why you're using GalFlex mesh, or if you're using for other reason. Can you clarify that?
Yeah, we've been using P4HB for a number of years now, just in terms of trying to control that lower pole breast shape. And I do think it's effective in minimizing changes post-operatively. That being said, we've done a lot of these cases without it, particularly early on. And I do think you get a little bit more stretch, but again, most people have their sense of how much they're going to get on average, and you can account for that. If I am using a soft tissue support material like P4HB, the one thing is that I really kind of plan that it's not going to stretch that much. And because the thing is that if you're used to getting, say, 15 or 20% stretch of your nipple to fold over a year, but you only get 5% stretch, your nipple can end up looking too low on the breast. So you just have to remember, if you're going to start adding things in like a soft tissue support material, you may need to make sure your nipple is up higher than you typically would put it when you're not using those materials.
Now we're going to start getting some questions coming in. Actually, it's along the same lines that you're talking right now. One of the audience is asking to talk about on the prevention of waterfall deformity. How do you avoid waterfall deformity? If you get it, how do you manage it?
Well, I think that the way you prevent waterfall deformity is to try to get the best mastopexy that you can. Now, obviously, that's the issue with single stage procedures, and I think that's why the reoperation rates are higher, because you can't do the same type mastopexy that you do when you're not putting an implant in. You just can't do it because of safety reasons. But in general, we just don't see a lot of waterfall deformity. But again, the patients that, if you're taking somebody that has a vertical excess of 10 or 11, that was the original concept from the tissue-based triad. That patient needs a really full throttle sound mastopexy, and you're adding an implant, there's no way you're going to be able to do the type of aggressive mastopexy I would want to do in that patient. And so then you put an implant in, you do that, and you're like, oh, damn, I got a waterfall deformity. It's like, well, hello, it's like, why did that happen? Well, I mean, the patient had a ton of laxity to start out with. So in the series, we're doing people that they don't have tons of global laxity in their breast. So we just don't see waterfall deformity as a big issue.
Okay. I mean, I think one of the things you mentioned, you're not using also high profile implants, which is one of the risk factors for developing waterfall deformity. As the soft tissue, if you have a lot of breast parenchyma falling over that high profile implant, it can cause the waterfall deformity. Another question is, does doing an Augmentation when downsizing from a large primary breast augmentation with a 700 to 800 cc change your implant selection? Or do you still use a low classic projecting implant for the desired base width?
Yeah, that's tissue-based triad number 3. We'll submit that. Like 700 cc implants. Yeah, that's a gong show to start out with, right? But this, I mean, this is like, we're talking about primary single stage augmentation mastopexy. So in a revision, yeah, I mean, you have a patient like that, we try to talk them down in size, but that's a totally different ball game. And as a matter of fact, just to mention, revision augmentation mastopexy, a lot of the relationships we talk about in primary surgery don't necessarily apply because the skin's already undergone stress relaxation and things like that. So yeah, I mean, I think that you just have to do the best you can with those patients. I try to get them down. We try to you can do mastopexies. Hopefully they're subpectoral or they've got plenty of breast tissue where you can safely do it. I wouldn't ever just use any of the relationships in our primary paper and think they're going to work in a revision. Those are all patients I would tailor tack before I commit. And it's a totally different animal. There's a lot of new pitfalls and other things that we're not really talking about, at least in this paper.
I agree with you 100%. Now let's talk about your concept of bottom-up technique versus sitting-up technique. You said that by bottoming out, you eliminate multiple variables, quote unquote. What are those variables that you're eliminating that you get in the sitting-up technique? Because I personally use the sitting-up technique with the tailor tacking, but I want to hear you. What are the variables that I have to take into account?
Yeah, I mean, I did the same. That's how I was trained, and I did that probably for the first 5 years of my practice, and until I was trying both of these things. And I just got to the point where I felt like I was way more accurate, more reproducible by not doing it. But the problem is that once you try to sit a patient up, you don't really know how the patient's leaning. You don't know, is one arm higher than the other? I mean, I think that if you start thinking about it, you start going, yeah, like, I mean, how many times in the operating room you've seen people like, they got the patient sitting up, they've got their gaggle of people back, then they're rendering opinions about how the patient's breast looks, which is the gong show in itself. And then they're like, oh, well, this breast is starting. They're like pushing the patient over a little bit on the table. So, I mean, I think that the most controlled position you're ever going to have a patient in the operating room is the one that you position them on the operating room table and then don't move them. And so what I found is that with this bottom-up technique, I tend to have, my nipples tend to be more even. I tend to make it more reproducible. The whole sitting, I think, has really, am I muted now? Are you able to hear me, Kiya? Okay. I think the minute you start sitting people up, these other things come into play, and you're not really sure what you're seeing, if that's a result of the position shift or something on the table. So that's really why we've migrated to more using objective measurement. And that's not to say we don't look at it too, but we don't sit the patient up. You can assess it equally as well with the patient in the supine position.
I have a question here. It says, hey, Bill, how about implant size when doing aug perioral mastopexy? Different concept with that operation?
Yeah, we're not really talking about, I kind of call that a nipple repositioning, which all the peri-realar things, I try to do those type of procedures as little as possible because I just really don't like the procedure inherently in terms of distorting the breast. But there are some patients that are good candidates to do it. But I think this is different. So these principles really are not talking about peri-realar or mastopexy. In general, when I'm doing that type of procedure, it's usually somebody that, as I said, their measurements they don't have that much laxity in their breast, but their nipple position is a little bit low, and you're just trying to move that up a little bit. And so I think the principles there are a little bit different. I tend to do something similar to what I would do for an augmentation, and maybe not try to push the envelope too much with that, because again, you're going to be removing skin. And then I try to minimize the amount of that. If you measure the diameter of that peri-realar resection, I really try to have it be 7 centimeters or less, because once you start getting above that, you start getting too much flattening, too much distortion, too many problems. And so I just try to stay away from that.
Exactly. As you say, you get flattening with the perioral mastopexy. Let's see, any other questions coming in?
Bill, I actually had a question, and perhaps I missed it. Can you tell us a little bit about your periareolar closure? Do you ever use a purse string, or did you use a purse string?
No, that's one of the things I like about this bottom-up technique is that I'll preface that by saying, I've done every Mastopexy technique out there. For many years, I did vertical techniques, and I got frustrated with two things. One, inability to predictably control nipple to fold length, which again determines breast aesthetics. And then the second thing is this different areolar distortions, things like that, where because you're basically having a larger cutout and then you're trying to cinch down the nipple around the larger skin resection. So with the bottom up technique, we're basically incising our nipple areolar complex at 38 millimeters initially, and then when we inset it, we're insetting it to the exact same dimension. And so I've been much happier with the scarring of the areola, the lack of distortion around the areola with that.
I have a question. Somebody's asking, you showed one of the two cases that you showed in your results. The second one actually had a very constricted base and very short nipple IMF distance. And the question is, what do you do differently with a patient like that? Because you got obviously a beautiful result with that patient. What were some of the pointers that you would recommend for the audience to take on with? And how did you get such a nice round result at the bottom? What did you do?
Yeah, so I think the first caveat to that case is that a lot of times, sometimes pictures don't tell the story, and I see people a lot where they, look at the pictures and then they come up with their whole operative plan. And you've got to measure patients, because that patient didn't have a short nipple to fold. That looks like she did, but if you actually measure and the amount of laxity in her breast, she had a nipple to fold of like 10 centimeters. That's where I think measurements can really help you. Pictures can be helpful, but don't just rely on your pictures. And so really nothing special about that patient. She basically has a lot more laxity when you measure her, and then she looked, and like I say, she didn't have a lot of breast tissue, and we basically just did the same principle as we described in the paper with the same technique. And yeah, I mean, I would say that the people that, people like that can do really well. Patients that don't have a lot of breast tissue tend to hold up really well over time. They tend to do really well with that procedure. It's the patients that have a lot of breast tissue and bigger breasts, and they're wanting, you need to do augmentation mastopexy. In my basic handling of that, those are the patients that end up being two-stage procedures because they've got bigger breasts, need a bigger mastopexy. So those are people that are more difficult in my hands.
So going back to that patient, I think the question that they're asking here is, the patient has a constricted base, so there is not much of a horizontal laxity. So even if the nipple IMF distance is long, but you don't have a whole lot of horizontal laxity. So how do you manage that vertical limb distance and open up the pocket without even further narrowing it if you're taking any tissue out from the middle portion?
Yeah, but I think everybody's probably seen patients before. Again, it looks one way in the pictures, but when you're seeing a patient live, she's got more horizontal laxity than it looks. And so she basically, with an appropriate size implant, which, I would, in a patient like that, I would look at it. And if you felt like, maybe we pick a slightly wider implant than what she looks like, just to try to widen that a little bit, but that really expanded out very nicely. So I don't think we did anything special in terms of, she's definitely not a kind of classic constricted lower pole breast. She has kind of a certain look to her breast, but she's got a lot more laxity than the picture showed.
And a follow-up question to that same patient is, was it the fourth dimension, which is the time? Is that the time that takes for that breast to look like the way it did in that follow-up picture, to allow for that settling of the lower pole and stretching, that kind of a controlled tissue expansion? Is that what it takes? So like if you see this patient, let's say 3 months versus 6 months versus a year, is that lower pole going to change and mature?
Well, for sure. Yeah, for sure. In a constricted lower pole breast, for sure. I tell patients it's going to take 2 years. I think it takes at least a year, probably 2 years to get full expansion of the lower pole. That patient, that was a year result in that photo. The second patient in that paper. But I think even at 3 months, I have her 3 months pictures. It's not in the paper, but even at 3 months, I think she looked quite good. She's had quite good expansion, and so and she's maintained that. And again, because she doesn't have a lot of breast tissue, we don't expect that to change a whole lot over time.
One thing that I've seen, we've learned from other different body parts for body contouring, whether it's the abdomen where we repair the scarpus fascia, or the facelift where we repair the SMAS, we are repairing the superficial fascial system. And I just want to clarify that I'm not sure if I could see it in your video. When you take that vertical segment of the breast parenchyma out, do you actually repair the SFS along the vertical limb before you do your skin closure? Because that's what we do with other body parts, to tighten up the skin envelope. I mean, not the skin envelope, the tissue envelope.
So you're saying when we kind of took out a little piece of parenchyma, inferior to the nipple, yeah. So typically, no, and these Augmastopexy, typically, no, we don't suture it. I think you could, like when I'm doing the Mastopexy, we'll actually take usually a bigger piece out there and close that back, as you're talking about. But with this, really the reason why we're taking that little piece of breast tissue there is to try to prevent crowding in the vertical limb, particularly down by the T closure. And so we're just trying to decompress the parenchyma in that area.
Okay.
Well, I think that probably wraps it up. Are there any other questions? Or Dr. Movassaghi, didn't mean to cut you off. Did you?
No, good.
Okay. I feel like we could go on and on, but it's been a great, lively discussion on a challenging topic. So I want to thank Dr. Adams and Movassaghi again for participating tonight. What a great discussion. I should mention to all of us that if we want to watch this again, it is on these will be archived on Radar, so you can watch this again, or you can watch any of the prior ones as well. So. Please tune in. It's the first Tuesday of every month. We'll be back here next month again. And on that note, I'd like to thank everybody and tell everybody have a wonderful night.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.